All right, I think we're going to go ahead and get started with this webinar. Hi, everybody. My name is Tess Killian, and I'm so happy to welcome you to the 5th annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department and Livingston County Health Department in partnership with the Washtenaw County Medical Society and Livingston Physician Organization. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding from this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This webinar is being recorded. The webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer some questions. So now I am pleased to introduce today's speaker, Roneet Lev. Dr. Roneet Lev is board certified in emergency and addiction medicine and practices on the front lines. She was the first chief medical officer of the White House Office of National Drug Control Policy from 2018 to 2020, after being chief of the emergency department at Scripps Mercy Hospital in San Diego. She currently chairs the San Diego Community Response to Drug Overdose Task Force, bringing together the 3 Ps: public health, public safety, and prevention leaders. In 2012, she established and chaired the San Diego Prescription Drug Abuse Task Force, Medical Task Force, the first of its kind in California. Lev's medical publications, known as the Death Diaries, studied the details of prescription patterns of people who died from accidental overdoses. Dr. Lev is the current executive director of the Independent Emergency Physicians Consortium, served as president of the California chapter of the American College of Emergency Physicians in 2000, and is founder and vice president of the International Academy on the Science and Impact of Cannabis. Lev is an energetic leader with a passion to assist communities in preventing and treating addiction. She also hosts the podcast, High Truths on Drugs and Addiction. Thank you so much for joining us today, Dr. Lev. I will let you take it away with your presentation.
All right. Thank you for that nice introduction. Thank you, everybody, for joining us. I have a lot of information to share with you. I'm going to, let's see if I talk to you about the front lines. I work clinically. I have, day shift. I'm almost aged out of night shifts. But every time I go to the emergency department, I treat people with marijuana poisonings. I'm going to share that experience, some of that with you. What you will get out of the next hour is able to recognize cannabis-related medical conditions, check drug interactions, the cannabis products, and urge you and anyone in the medical field practicing to include the word cannabis in your ICD-10 diagnoses. So to go through that, we're going to talk a little bit about the basics because terminology is important. What's marijuana and cannabis? Go through some cases and go through some of the medical advisories that are already out there. First, a quiz. Name this plant. And it's natural. It activates many different neurochemicals. It causes a drug interaction with several medications. It reduces anxiety and schizophrenic effects, and no one dies of one puff. So we have this. You guys can guess what that is. And I'm going to try something. If you could keep that poll up for your quiz, I'm going to go on to the next slide and talk about things and see if you do that. It says hosts and panelists can't vote. That means I can't vote, but let's see what you guys come up with. So some definitions. What is marijuana? People use the word marijuana and cannabis, and what's the difference? There's a slight technological difference. Marijuana is a product from the cannabis sativa plant with a lot of THC in it. The THC, the active psychoactive compound in marijuana, is found in the female flowers. Cannabis is all the different products, 540 different products from the cannabis sativa plant. So marijuana and cannabis are used interchangeably in the medical literature. So I use those words interchangeably as well. There's also industrial hemp. That's a definition designed by Congress. It's not a medical definition. Congress labeled this as a cannabis plant with less than 0.3% dry weight THC. Congress made a mistake in their definition, and we'll go through that a little bit, is that they only said Delta 9 THC. So then their industry came up with all sorts of different THC products that have never been tested on lab rats or anybody, but are being sold to the consumers with problematic results. And we'll talk a little bit about that. Oops. And then there's also the cannabinoids. The cannabinoids are the group of substances within the marijuana plant that can have some therapeutic effects. And some of those are already FDA approved. There's 60 different active cannabinoids. There's phytocannabinoids found in the plant. There's also synthetic cannabinoids and endocannabinoids that are natural in our system. So THC and CBD are the most common cannabinoids that we talk about. What about synthetic marijuana? The word synthetic means it's made in the lab. By the way, if the poll was closed, can't quite see how you guys voted, but the answer to that was tobacco. See, tricked you guys. Everybody thinks it's marijuana because I'm talking about marijuana, but that was what was told about tobacco. The tobacco plant helps with anxiety. It helps with the negative schizophrenic effects. Nobody dies of tobacco. And so that's what was said as that. And we're just kind of reliving history now with a different plant. So synthetic marijuana is made in a lab, sprayed on like plant-like material to make it look like marijuana. It does not show up in drug screen, has a lot greater psychoactive effects. It binds a lot stronger, 800 times stronger to the cannabinoid 1 receptors. And the only way I know that my patients are using synthetic marijuana if they tell me. The number one way I would find out is young people who are having a new onset seizure. And I'll ask them if they use, and if they tell me, then I'd say, well, good, you won't lose your driver's license for having a seizure. This is a reversible cause. You know, if you not use that, then you won't have the seizures. What about medical marijuana? This too is a political word. The word medical has been, you know, hijacked from the medical community because, you know, gone to medical school, residency, take those, you know, darn board exam. I've taken those board exam like 4 times in my career. The things that I need to do to, you know, prescribe Tylenol is, you know, a history, physical, vital signs, drug interactions, documentation, and medical, quote unquote, marijuana users are just not held to the same international medical standard for prescribing. If I gave out, you know, amoxicillin like marijuana is given out, I would lose my license. The word medical was, you know, sold to the public for compassionate use, for end-of-life care, for AIDS. But in a survey of California users, less than 3% of users have cancer, HIV, or any of the compassionate reasons, and the average age is 32. A lot of kids just get their card at 18 as a given. I don't know if anybody ever goes to get a card and they are told, oh no, your blood pressure is too high, you shouldn't be using marijuana. If we want to know if something's safe or not, we really can go to the gold standard. The gold standard is the FDA drug label. That drug label, there's a lot of research and years of, you know, methodology and scrutiny that goes into approving FDA medications, and the drug label has, you know, lists of adverse reactions. So if people want to know, you know, well, marijuana is safe, it has no problems, it's healthy, it's a plant. I said, well, let's go see what the FDA says about Marinol, Dronabinol, which is FDA approved medications, which I could write a prescription for right now. And if you go look at the label, it'll say like right there in the big warning and precautions about neuropsychiatric adverse reactions, hemodynamic instability, seizure or seizure-like activity, multiple substance abuse, fetal harm, geriatric use, and paradoxical vomiting and nausea. Really amazed when I looked at this, thinking how many years ago the FDA put out this label in 1985. And right now, you know, I'm seeing all these things in the emergency department. What's sold in shops, pot shops, is not what is approved or sold by the FDA. Not in terms of potency, not in terms of contaminants and toxins. People think of marijuana as just weed, a plant, but there's a lot of synthetic products out there, vapes, dabs, suppositories, drinks, foods, creams, and you don't really know what you're buying. A study done by JAMA, the Journal of American Medical Association, bought a bunch of products and showed very small reliability, and what you are saying in potency really matches up to what you're buying. And several studies have shown impurities, pesticides, and the marijuana plant itself is very much absorbs from the ground whatever is in the ground, more so than other plants. And so any of the organophosphates and things that were in the ground gets absorbed into the plant. And also the plant is very prone to fungus, and CDC has advisories on that as well. Sold as various candies, like why in the world do we need Cheetos that look like Weedos, et cetera? Like, who is this attracted to? Now, I say every day I treat marijuana poisoning in the emergency department. When I started my career many years ago, I never saw that. Now it's a daily occurrence. Why is that? And two reasons. One is the availability is much more. And two is the potency is nothing like it was back in the good old days of 1990 weeds. I wish we had such product. Those products don't even exist anymore. So for example, in potency, FDA approved Marinol, the maximal dose allowed is 20 milligrams. In 1990s, 1 gram joint, 50 milligrams. Today's joint, 1 gram joint is 200 milligrams, 4 times as much or even higher. Edibles, like depending on the state, if it's 10 milligrams per dose, 100 per package. With bioavailability much more than that, than in smoked product, it's like 500 milligrams. And the concentrates, the dabs and shatters and waxes, that is, boiled down to high concentration THC up to 98%. That is like 6,400 milligrams or 128 1990s joints. Those concentrates, when you see patients on them, the behavior, the clinical effect is more like methamphetamine, cause a lot of agitation. So it's important to ask when people say, "Oh, do you use marijuana?" They say yes. I'll say, "Well, what kind do you use? Do you use edibles? Do you smoke? Do you dabs?" Makes a difference. What about the Delta 8? I explained that Delta 8 is a congressional mistake in their definition because it left loopholes, and they defined hemp as less than 0.3% Delta 9 THC. And so people said, oh, well, I got Delta 8 THC, and we put out some Delta 10 THC, and that's completely legal unless it's, I guess some states are now adding those products and making them illegal as well. But those are now a loophole. And according to the FDA webinar, there's not enough plant material in Delta 8, Delta 10 THC that really, if you are seeing that being advertised or sold, that is synthetically made, not plant-based. And FDA has no intention of regulating those products. They're saying, Congress, you made that mistake, you fix it. Because what they did is just put out warning labels on their website that these materials are dangerous, hazardous, and not safe and not regulated. And this is from their website. Delta 8 products are not FDA approved, have health risks. Poison centers are talking about, adverse effects. There's even a child who died from a Delta 8 product. The chemicals used to make them, and they say, I like the last one, keep away from children and pets. But I'd say adults too. What about CBD? A word about CBD. Again, is it healthy? It's out there. People are, I can't get my nails done without us getting to see some CBD cream. People are using it for everything. There's a lot of marketing behind it. Is it safe or not? Let's go to the FDA label. If you go to, just put on your search engine, Epidiolex, which is pure plant based CBD, Epidiolex. It's FDA approved to treat a subset of children with seizures. these babies with Dravet syndrome are not smoking marijuana. They are using, prescription grade CBD oil. But looking at the, warning and precautions for Epidiolex, hepatocellular injury, need to check liver enzymes, somnolence and sedation, suicidal behavior and ideations, and fetal harm. So, that's what I, tell people, like, is it okay for me to use? I said, read for yourself what the label is, what the harm is, and make your own decision. Again, what is sold out there is not regulated. And that's the problem, is that you don't know what you're buying. And my patients get like, oh, I'll ask them, they come in with all sorts of weird symptoms, achiness, dizziness, something that just doesn't add up. And they do a very careful medication history, including any supplements. And I'll say, oh yeah, I bought some CBD for my gout. And they're upset when they spent $100 and they didn't know that it doesn't interact with their Lyrica and can cause side effects. And they don't really know what they're buying. There have been numerous cases of various contaminants, pesticides, heavy metals found in CBD products. One thing I advise my patients on is when they want to buy any herbal or supplemental medications, I take vitamin D for vitamin D deficiency. I make sure that when I buy it, it has a USP seal. That means that company that is producing that vitamin or supplement went through the extra steps to make sure it meets standards, and I can count on that 5,000 international units to be real and not have the various contaminants. Importance about marijuana, and I share this with any patient under the age of 25, even if they're using or not using. I ask them, do you know you're as tall as you're going to be, you're growing to be as tall as you're how old do you have to be, when your brain stops growing? And the kids know this. They say 25, it's 25. For my kids, it's 27. And that's important because that's a great time to learn new tasks. And also the incidence for substance use disorder is up to 7 times higher at that age group than if someone my age starts using any type of drug. How does the brain grow? 2 different ways. One is synaptic pruning, where you're born with only a fixed amount of neurons, and that's it. If you lose them, that's it. You don't get more. But the brain is adaptable in growing extra pathways, these dendrites that you see, they're growing, creating pathways. So at birth, you don't have any, and you actually, if you watch a baby week to week, you can see that these neurons are connecting and they're growing and they're talking and they're walking better. At 6 years old, you got too many of them. Kids are like all over the place, and the brain has to decide which of these pathways I'm going to keep and which I'm going to prune away. And it's a use it or lose it method. You use your pathways, for music and sports and math, and those pathways are going to get stronger. You use it for weed, and that's what's going to be made stronger, and the other pathways will be pruned away. The other way is myelination. Myelin helps conduct electricity, go faster from one path to another. And the last place of your brain to get myelin, the white matter of your brain, is your frontal lobe. And that's why we say the last part of your brain to grow, and why, at teenage and young adults, their frontal lobe, executive functioning of your brain, is the last to mature. So really, you don't want to stunt the growth of your height, and you don't want to stunt the growth of your brain. What marijuana does, or actually any drug does, is hijack your dopamine set point of your brain. So at first you use the drug and you feel great. You got that dopamine surge. Dopamine is a neurochemical that you need to survive. You need oxygen, you need water, you need dopamine. Without dopamine, you feel like you're going to die, just like you feel like if you can't get any air. So people need that dopamine just to get up in the morning and have this nice lecture with you. Drugs alter that. They give you a surge of dopamine. And with that surge, with continued surge, your receptors downregulate. Like body says, well, I don't need all these receptors. I'm getting too much exogenous dopamine. And then that sets your new normal. And now your amount of dopamine you need just to get up in the morning is a lot higher. So for example, on the right part of the slide, you could see at baseline, me talking to you, 15 to 40 units of dopamine. The best day ever, your wedding day, or I just became a grandma, then 100 units, or for marijuana, old-fashioned marijuana, it's higher, heroin, methamphetamine. With time, this could be set back to baseline, but it takes time. So another quiz, we could put that up and we'll see how people do. Which of these statements is false? Addiction is at less than 25 is up to 7 times more likely at an age under 25 than older age. B, people who regularly use marijuana may need higher dose of anesthesia. Which of these statements are false? C, marijuana can cause bleeding. D, cannabis can cause chronic psychosis or schizophrenia. Or E, no one dies of marijuana. Let's see what your answers are. I want to go through these polling questions kind of quickly. And I'll just kind of share the answer. No one dies of marijuana. The saddest podcast I ever did, and I tricked you guys again. You know, don't tell Laura Sack, whose son developed cannabis-induced psychosis and jumped off a building to his death, that no one dies of marijuana. Don't tell the mom whose child was killed by a marijuana-impaired driver that marijuana doesn't kill. And if you look at your medical examiner carefully, you'll see that over time, the association of drug deaths and marijuana deaths have come up. And then I'll show you some examples of that as well. And the other statements are true. We'll elaborate a little more. All right, so some cases from the front line. This is what I will see when I walk in. First of all, the number of patients. This is from our local report in San Diego, 37 cases a day, huge increase over time. Again, availability and potency. What I see, and I'll go through some examples of these: psychosis, suicidal ideation, scromiting. How many of you know what scromiting means? Excited delirium, seizures, cardiovascular effects, lung effects, etc. The saddest thing, and really a failure on our part in consumer protection, is the pediatric exposures. At our local hospital, 2 cases a day, children under the age of 5 coming in with encephalopathy. These kids are not laughing and giggling. They're, you know, in a comatose state, needing ICU care. A percentage of them require intubation. This is not a funny thing. And they're getting into their, number 1, mom's gummies. Also, number 2 is dad's products. In a study of 52 different hospitals, children's hospitals, the mean age was 2 years old for these exposures. There's been a 13.3-fold increase exposures over time. And again, 15% required ICU, 4% required intubation. This young girl got into her mom's gummies. She had nystagmus. Her eyes were rolling back and forth in her head and needed to be in ICU. There's no antidote. We have antidotes for opiates. We have no antidotes for most drugs. You just have to wait and for your body to metabolize. I said, who knows what? Who knows what scromiting is? Scromiting is a layman's term. Cannabis hyperemesis syndrome. It's probably the best thing I've ever done in my medical career, better than any article I've talked about. Is in the peak of the opioid epidemic, we started seeing people coming in with abdominal pain, and they were demanding opioids because their stomach hurt, and they were retching and kicking their feet and in horrible pain, really miserable condition. And I call it an audible diagnosis. I could hear there's nothing else that sounds like that. And we termed it scromiting, screaming and vomiting. So when our local public health department put out a community guideline on how to treat cannabis hyperemesis syndrome with avoiding opiates, avoiding radiation. Some of these patients have had 10, 20 CAT scans, and nobody could figure out what's wrong with them. And that's because you didn't get a history. The history is a telltale sign of people who've used marijuana on a regular basis for many years. This is not the occasional weekend warrior. These are people who've been using and altering their cannabinoid receptor system, kind of similar to what happened with the peak of opioid epidemic, when we were seeing people with opioid hyperalgesia syndrome, where the opioids were causing pain. And here we're seeing, again, the marijuana is causing terrible vomiting and abdominal pain. People have died with electrolyte abnormalities from this. So it needs to be taken seriously. But the remedy of that is stopping to use marijuana. I tell patients that And they say, I asked them, they all say, oh yeah, I can stop. But I explained that it's a lot harder to stop than they think, because virtually everybody who has cannabis hyperemesis syndrome has a cannabis use disorder. They didn't get to that. It starts simple, like hot showers can help the pain, but eventually by the time they're in the emergency department, I treat them with psychoactive medications, Haldol fluids, antiemetics, and that kind of seems to do the trick. But it's a lot harder to stop than it sounds. And I explain what withdrawal from cannabis is like. And withdrawal is not like opioid withdrawal or alcohol withdrawal. It's more like, caffeine withdrawal, headache, anxiety, inability to sleep. What lasts about 2 weeks. And you can help get through that by understanding what's going on. And again, treatment here is mostly what not to do, not to give opiates, not to do CAT scan after CAT scan. I tell my patients, like, here's your CAT scan, keep it. Next time, hopefully this never happens to you, but if there is a next time, share that with your doctor so they don't give you radiation after radiation and end up having cancer later on in life. People have had their appendix, gallbladders out, searching for a diagnosis that's there in the history. And again, the treatment is hydration, antiemetics, antipsychotics, and then explain about withdrawal. I see anxiety associated with marijuana use on a regular basis, as well as acute psychosis. I had a guy call 911, young college student called 911 on himself, on his family, because he was convinced his parents were going to kill his brother, and he was seeing bags of blood and something had to be done. And he got in his car, drove from Northern California to Southern California to save his brother. At the same time, his dad called 911 on him and saying, my son is not right. And he came in extremely manic, talking a mile a minute, believing all these crazy things and blood associated illness. And through his psychosis, I tried to talk to him. I said, do you think that you're seeing or thinking this because of the marijuana? And he had some insight that could be the case. It didn't alter it. He still saw that and believed that. Again, I can't take that away. I could just treat the symptoms and wait, for him to detoxify and get back to normal. And the great part is, if you tell patients this, if you don't just blow them off like, okay, whatever, he's psychotic, let's fix it and move it on, then you're depriving that patient an opportunity for understanding what happened to them and preventing from the future. So if he understands at this young age what happens to him, then again, you may prevent the next occurrence, because otherwise you won't be thinking, oh, it's just marijuana, it's fine. That's what the public says. But if he understands what happened to them, it could prevent the next incident. And also, after repeated incidents, psychosis can convert to schizophrenia, where now it would be not reversible. Excited delirium, I saw this. This is called a visual diagnosis. Where I'm a very small person, so when there's a violent scene, I kind of step aside and protect myself. But this is, it's a dramatic visual scene with lots of people and a very violent person kicking, screaming, yelling. And what do we do with someone who is very agitated, presumably on drugs? We give them more drugs. We have to get chemical control for the safety of the patient and others. And in such a case, when a patient woke up and tested only for marijuana, I asked him, like, what happened? What did you take? He said gummies. How many gummies did you take? He said just one. Again, there's no controls. This is not like a pharmacy, mixing your drugs in a clinical way where you have 5 milligrams in every little gummy. One gummy can have all the THC content and the rest could be sugar. There's not a control in that. Now, marijuana, cannabis is a risk factor for psychosis, period. That is well accepted. Just like tobacco is a risk factor for cancer, lung cancer, and heart disease. Not everybody who smokes tobacco is going to get cancer or lung disease, but it's a risk factor. Not everybody who uses marijuana is going to get schizophrenia and psychosis, but it's a risk factor. How much of a risk factor depends on how much you're using, the potency, and the age of onset. In a study in Europe with 10% THC, kind of THC that doesn't exist in America anymore, but they considered that in Europe high potent THC, the risk factor was 5-fold increase for developing psychosis and chronic psychosis for a daily high potency user. And these are large studies over large populations in Europe, to the point where they're able to say that in areas that have legalized high potency THC products in Amsterdam, London, Paris, that they would have less incidences of psychosis and schizophrenia if those products did not exist. And we have that well studied and published. I'm going to share with you at the end website where I'm showing you a lot of data, a lot of information. I know that you won't remember it all, but I want you at your fingertips through your phone. If we're having these conversations with your colleagues or even patients, I show you what website to go to where you'll have all this kind of data at your fingertips. Conversion of schizophrenia. You know, anytime you have a substance use can convert into psychosis, right? That can happen with methamphetamine, marijuana, many different drugs. The incidence of a substance use psychosis or bipolar converting to permanent is about 30%. But it's much higher with marijuana, more than other drugs in becoming permanent, more than methamphetamine, which is what I see on a regular basis, also living in San Diego. So a much higher conversion rate for psychosis, schizophrenia, bipolar disorder as well. The Bradford Hill criteria, we learned from history, we learned from the tobacco industry. From the tobacco industry, they said, these lungs are black. That's not from tobacco. That's just environment. You know, prove that, you know, that lung cancer, that emphysema really came from tobacco. There's a correlation there, but it's not a cause and effect. And the Bradford Hill criteria was used with all these different studies and all these different measurements to prove causation. The tobacco caused this COPD and emphysema. And we have that same Bradford Hill criteria applied to THC and psychosis. What about suicide? This is sad, very sad data. The saddest podcast I ever did was bringing together parents whose children suffered cannabis-induced psychosis or cannabis-related suicide. Laura Stack, this is her son, Johnny. She heads Johnny's Ambassadors and really leads a lot of parent groups. So if you have any parents who need support, this is one of her things that you could refer people to Johnny's Ambassadors. And she helps these parents out who really want to understand what happened to their child and also to prevent it in other children. In our data, I looked for data in people who completed suicide under the age of 25. And the number one drug, way more than alcohol or any other drug associated with completed suicide in young people was marijuana, was THC. And 50% of the people who died, THC was the only drug found in their system. What about chest pain? This guy came in the middle of the pandemic. We're all dressed in our little astronaut suits, waiting for the COVID killer. And this guy did not have COVID. He developed a pneumothorax. He was in his room, like, you know, bong after bong, bowl after bowl, really anxious, working, and it collapsed one of his lungs. And that was not from the toxic effect, but from the barotrauma of smoking marijuana. I actually have a podcast with him. He's a very eloquent young man who's able to, you know, explain what happened to him, and he talks about his experience. They've also done studies. You know, why we think of, like, we know that tobacco has combustions and chemicals and carcinogens. Well, those same combustions are in marijuana plant. There's no difference. And as a matter of fact, they did interesting studies comparing CAT scans of people who smoke marijuana and CAT scans of people who smoke tobacco, and found worse associations of lung damage in marijuana smokers, which makes sense. You have a lot more of smoke and you inhale deeply. Again, and smoking anything is bad for your lungs. So actually, which is worse? And here's a quiz. You could put that up and see how you guys, I've been getting you on these quizzes. But which of these things has more secondhand smoke? You know, when back in the tobacco days, people, you know, disputed tobacco is a healthy plant. It didn't cause any harm. Secondary smoke, people laughed at that. We all accept that now, but there's secondary hand smoke from tobacco as well. Joints, bowls, bongs, vapes, Marlboro cigarettes. Let's see what you guys say. Which has the most secondhand smoke effects? And the answer is, dun, dun, dun. Let's see if I have that in my next slide. A joint. All right. Okay. We got, you know, this was a hard question. I have hard questions here. But a joint, 3.5 times more emissions from a joint than a Marlboro cigarettes. again, smoking anything is probably not helpful. Here's another, no one asked people of public health, the smart people who put together this series, asked their opinion whether we should have vapes out there or not. It was sold to be, well, this helps people stop smoking. So it's, it's a safer alternative to cigarettes. But is it? Their study was done. I got this from the CDC tobacco office that modeled over time what would happen with legalizing vapes. And they said that for every one person who quits cigarettes by using electronic cigarettes, we have now created 80 new young people who never would have smoked in the first place. They went further. Every 3,000 years of lives saved by electronic cigarettes from getting people to stop smoking cigarettes, we have now cost 1.5 million years of life. So, okay, you do the math in that public health decision. This lady came in the emergency department after she passed out, syncope, cardiovascular collapse. Her head split it open, much worse than this picture. It took me forever to put her head back together. Again, and the irony of it is she was using these marijuana gummies to help her migraines and fibromyalgia, and she ended up with a much worse headache. The American Heart Association has a really good white paper highlighting, pros and cons, but really concluding that there's no benefits in cardiac outcomes and actually more adverse effects, and don't recommend marijuana for people who are at risk for heart attacks or strokes because of a higher incidence and association, or people with high blood pressure, increasing in systolic rates, increasing with arrhythmias. I share this with my patients. What the American Heart Association says, this is not good for your heart. I've done, we're a stroke center. I've had several patients who come in with a stroke code. We, do all that CAT scan, angiogram, quick CT scan, and sometimes everything is normal. I have like 3 cases of these where at the end of my big expensive workup, the guy comes out, he's there in San Diego for a conference. He's hungry, gets some munchies in a hotel. Someone gave him one of these hangover remedies. He had one, popped it in his mouth, and all of a sudden he couldn't talk right, and his hand didn't right. And I'm thinking, like, if he had a stroke, I can't put him on a plane back to New York City. I got to do my workup. And at the end of the day, it was the gummy. He was mad. Yeah, he's probably mad over his medical bill too. Cardiac collapse. This guy smoked wax, right? Like 90 or more % THC. Heart rate goes down, blood pressure down, intubated, ICU, wait for detox. There's no antidote. Just symptomatic support. He would have died if he didn't get such urgent care. Seizures. There's a fallacy out there that marijuana is good for seizure. Marijuana, the plant with 500 different chemicals, including carcinogens, does not help seizures. As a matter of fact, the FDA label shows that it decreases the seizure threshold. But the word out on the street is that this is good for seizures. And so I see a lot of patients who have a seizure disorder and they're not taking their seizure medicine, they're using marijuana instead, and they're in the ER for seizures. And so again, asking about marijuana use in patient with seizures can help prevent seizures by medication compliance and avoiding something that decreases the seizure threshold. Again, there are a subset of babies with Dravet syndrome, Léon-Gaston syndrome, very rare pediatric seizure disorders that are assisted by pure CBD. These babies are not smoking pot. This guy was on vacation with family. He's 88 years old, is complaining to his grandson, I can't sleep, I have to take all these medications, things are so hard. And grandkid says, oh, well, I know what can help you, Grandpa. Try this brownie. And, Grandpa takes the brownie, and it works. It works great. He sleeps so nice, best sleep he ever had. The problem is he didn't wake up. Had to be admitted with encephalopathy, had to detox. And for him, it takes a lot longer. He's older, his metabolism's slower. He has liver disease. Marijuana is metabolized in the liver. And he had to be in the hospital for several days. With good, the kids have good intentions. Everybody says marijuana is so healthy, try it for insomnia in this case. But there are other alternatives for insomnia that are better, that are FDA approved, that maybe even don't need medications to treat insomnia. In a study in California, in adults over the age of 65, this is outstanding. Over age 65, the incidence of people coming to the emergency department with marijuana-related issues has increased over 1,800% in the state of California. So really an issue I've showed you now with kids coming to the emergency department and now with older adults and everything in between. Internal bleeding. This was one of those quiz. Can marijuana cause bleeding? Well, marijuana won't cause bleeding, but this gentleman, 62-year-old gentleman, came in the hospital 3 times, each time with, anemia, needing blood transfusions, endoscopies. And then the final time says, like, well, to use marijuana, goes, oh yeah, I'm a product of the 60s. It never caused me any problems. Like, well, first of all, he had cognitive decline. He had a problem. He didn't recognize it. But that's besides the point. He's now had stents. He's on Plavix, a blood thinner. And when you mix that blood thinner with THC or CBD, it increases your chance of bleeding. And this is something that when you get your medical marijuana card, nobody asks you about, do you have any other drugs with potential drug interactions? There are, and again, there's like there's 2 websites that I want you to get out of this lecture. Is the Isaac website, which I will share, so you could see all this data at your fingertips. You can have these, win these conversations with science, with your colleagues and friends and family. And the other one is to have drugs.com. So anytime I have patients with weird symptoms and they take, CBD or THC products and they're on other medications, I say, well, let's just make sure it's safe. And I have them do this themselves. Go to drugs.com, click on the drug interaction checker, and now put in cannabis for marijuana or cannabidiol for CBD. Add in your, lisinopril, whatever medications, antidepressant medications. Click on the drug interaction checker and read for yourself the side effects and symptoms. There are over 500 drugs that interact with CBD, over 300 different medications that interact with THC, and some of them can be life-threatening, like the blood thinners. A lot of people use use marijuana instead of opioids. I have patients, like they have cancer. It's like, well, isn't it better for me to use marijuana? It's natural rather than use those terrible, deadly opioids for my cancer pain. And it's like, no, if you have cancer, you're immunocompromised. The marijuana product invariably has various fungus and contaminants that you're more susceptible to. You should take the opioids. That's what they're meant for. And there's, various studies that, again, I'll show you on the Isaac website that show that, marijuana is not a good alternative for pain. Testicular cancer, the incidence of testicular cancer, especially in germ cells, is 2-fold higher in marijuana users. So again, other preventable public health harm. There's a lot of information now about what marijuana does to DNA and how it's genotoxic. Those of us who prescribe Paxlovid, in the peak of COVID, we're giving Paxlovid out to treat COVID. And on the Paxlovid, there were warnings for drug interactions. Again, it's a new medication, but we know about the cytochrome P150 symptom and drug interactions. Same goes to marijuana. And with Paxlovid, we advertised and told people not to get pregnant, male or female, for 3 months because of the genotoxic effects of Paxlovid, and same for marijuana. Drug driving, we're seeing more fatalities associated with marijuana and the combination of marijuana and alcohol. Data from fatalities shows a 2-fold risk of being killed when marijuana is in the blood system. One interesting study was done at a University of San Diego, simulations tests of drivers. And what was interesting is 2 things. One is people who are using marijuana didn't feel impaired, even though they are, or the data showed that they are, and they're willing to take that risk. And that after smoking products, that impairment in perception and driving went away after 4.5 hours. But that's for smoked products, not for edibles, not the shatters and dabs. So one public health message would be, like, if you're going to use and smoke marijuana, wait 4.5 hours before getting behind the wheel. Again, just for smoked products, not for the other products. What about marijuana and fentanyl? I get this asked a lot. I get patients who say when they wake up after a Narcan that, oh, I was only using marijuana. There are some case reports of marijuana products found to have fentanyl in it, like in Connecticut, but that's very rare. More likely, I think what's happening with patients who like swear they were only, using marijuana. I ask them like, well, how are you using it? And if it's a bong, then I think maybe there was some fentanyl residue in the bong, and that's how they overdose. There have been incidents of fentanyl in vape pens and stuff. But if you really find, fentanyl in marijuana products, that is a public health alert that needs to be published and advertised. And final quiz, or one of my last, well, actually not final quiz, but here's one more. Which of these statements are true? We got your poll. Let's see how you guys are doing. This is easier. Which statement is true? And you could select more than one. Cannabis use is a risk factor for a heart attack, acute MI. Cannabis use is a risk factor for schizophrenia. You're going to get this one. And patients on blood thinners and blood pressure medication should be cautioned about cannabis use. So let's see what you guys said. All of them are true. I didn't know if this quiz allowed that, but yay, you got this. Okay. And again, risk factors are things to be shared with patients. All right. So finally, I just want to share with you and more. I want to finish up really quickly to show you what's out there so you could find this information for yourself with these advisories. Screening and brief intervention should include marijuana, cannabis use disorder. Make sure you ask about that diagnosis. You won't find out that someone has cannabis hyperepsis syndrome if you don't ask. We always have to smoke, drink, or do drugs. Ask also, what about marijuana and what kind of products? If you see that. The Surgeon General has advisories out there on marijuana and the adolescence, the growing brain, and pregnancy. The CDC has advisories on vaping, marijuana products, and EVALI, pulmonary illness. We don't have a command center anymore, but this, just last month we had a case of a 18-year-old with EVALI syndrome and ICU stay. So that problem still exists. The CDC has an alert on organ transplant and anybody who's immunocompromised not to use the smoked products, and that's because of the fungus that is known to exist in the marijuana plant. Anesthesia, this is fairly new from the American Society of Regional Anesthesia, recommending universal screening before clearance for surgery on marijuana, and that's because the anesthesia needs and post-op needs are different in people who use marijuana on a regular basis. So they recommend screening, and here's, reference to that. There's very different medical societies who put out, their alerts on their part of the body on marijuana that's available. And I really urge our medical providers, we're kind of like we were with the beginning of the opioid epidemic, where we weren't documenting the incidences of opioid adverse events. That's where we are now with marijuana. So I urge you, the CDC and the CMS, the codes haven't caught up to the times of the various things that we're seeing, but include cannabis somehow, either with the word use disorder or poisoning or psychosis, or just have the word there so that data can be captured. If we don't put that in, that data does not get to the epidemiologists and public health officers who make our public health policy. So if it's not documented, we can't, do things to prevent it. This is the website I've been talking about, IASIC1.org, IASIC1.org. If you go there at your fingertips, you'll go to the medical library and you could look up psychosis, pediatric exposures, emergency departments, motor vehicle collisions. Most of the things that I talked to you today will be there with, the talking point, the quick cliff notes, as well as the full article reference. So this is a final quiz, which I will skip because it just asks which of these things are you going to do in the product. And I really want to get to your questions, and hopefully you have a bunch of questions. Here's my contact information. I'll keep that up for a little bit as I get the questions from your chat.
Right. Let's see here. We have had a couple questions come in through the chat. But thank you so much for that wonderful presentation. I'm going to open it up for question and answers. So if you haven't already, please submit your questions to the Q&A feature found at the bottom of your screen. We did already get a couple questions about recordings of this presentation. They will be available in the coming weeks on our website, washtenaw.org/marijuana. But getting to the questions we do have in the Q&A, the first one is, are there medications that suppress the craving that people with cannabis use disorder experience, similar to how methadone decreases opioid cravings?
At the current time, there's no FDA medication specifically that target marijuana. It's a very good question. MAT, medication-assisted treatment. There is MAT for alcohol. Naltrexone suppresses the craving for alcohol. For nicotine, there are some medications that help with nicotine. And for opioids, there's 3 drugs that are approved. Methadone doesn't actually work on the craving. It's kind of like it's another opioid that helps with the safety. And so I guess in a roundabout way, it helps with the craving, but it's kind of a different type of like replacement therapy. But right now there isn't. I know NIDA is funding several studies that are working on that, but none yet.
The next question is
emerging, I'm seeing now, is emerging psychosis an issue of unmasking predisposed patients? You know, that's something that parents always ask me. They want to know, like, would this have happened to my child, whether they used marijuana or not? And the data, again, largely coming out of Europe, but also by the World Congress, and I have that on the Isaac website, is that it is an independent risk factor. Marijuana is an independent risk factor for developing psychosis, regardless of, you know, unmasking the genetic effects. Of course, if you have genetic effects and using marijuana, then you're going to have an increased likelihood. But it's an issue that stands on its own. You know, for deciding, you know, was this caused by your predisposition or not? You know, one way to say it's like, if you're not using marijuana, do you still have psychosis before it became permanent? And that's one way to tell. Also, does it run in the family or not? That's another way to tell. Happy to share the slides and wait.
A couple questions in the chat. In the chat, Jana asks, do you recommend pump and dump when breastfeeding, and or how many hours after smoking can you resume at the breast?
Oh, wow. Good question. Marijuana THC does go through the milk. So that does go. How long should you wait? I don't know the answer to that. I don't know how long it depends on, you know, the potency and the amount, right? So how would I answer that question? Like, how long does it show up in your urine? But that's the byproduct. Metabolized marijuana could be even up to a week. It could be longer for people who use it longer. I don't know the answer. I know marijuana stays in the urine longer, in the blood way less. So I would imagine in the breast milk way less. And if I had to guess, I would make it kind of like what we say with drug driving, but I don't know. It's best not to have that. We do know longitudinal studies. There's studies called the ABC study, which is the longest large population of studying people from, you know, birth till they're 35 years old, that moms who used marijuana while they're pregnant have more incidence of anxiety and mental health issues long-term in the kids as they grow up. So best to avoid that.
Right. And one last question in the chat here. For individuals with cannabis-induced psychosis, is there any kind of blood test or other medical testing that could pinpoint cannabis as cause?
It's going to be your history as a cause, not a blood test. I mean, a urine test can show marijuana, meth, other drugs in the system, but you kind of need to use your, clinical judgment, right? This person's using marijuana, the age, what they behave like on marijuana. I mean, I see it very clearly in the emergency department. I realize that people are hesitant to make that diagnosis, but to me, it's very clear when you come in, marijuana in your system and you're psychotic, and 3 days later off marijuana, you're back to normal. That was cannabis-induced psychosis.